Dr. Betsy Hershey is graduated from the University of Minnesota. She completed a small animal internship at the University of Pennsylvania and received her med-onc training at UW-Madison. Yay.
Yay.
And she is currently the owner of the Integrative Veterinary Oncology in Phoenix, Arizona, which integrates alternating therapies with conventional therapies for patients with cancer. The second half of the presentation this afternoon will be Dr. Andy Turkell, who is a veterinary medical advisor of Hyperbaric Veterinary Medicine.
Thank you. Oops, there's one microphone. Okay, I think I'm good. We're going to talk about hyperbaric oxygen therapy for the veterinary cancer patient. Hyperbaric oxygen therapy involves exposing the body to 100% oxygen at a pressure that is greater than what is normally breathed with room air. And this is delivered in a special chamber. This is there it is. It's really tiny, I'm sorry. So this is a chamber that we have. It's a small animal chamber that we have on a lease program through Hyperbaric Veterinary Medicine. The hyperbaric oxygen therapy, or HBOT as we call it, dissolves increased amounts of oxygen into the blood plasma, and this results in increased oxygen delivery to tissues. And this has been shown to be helpful in treating many conditions, including radiation injury, non-healing wounds, decompression sickness, or the bends that divers experience, carbon monoxide poisoning, snake bites, pancreatitis, peritonitis, cancer, the list goes on and on. In veterinary medical patients, we generally treat at 1.5 to 2.0 ATA, so 1.5 to 2 atmospheric. We usually do the 1.5 for brain and spinal cord lesions. And we have a couple of patients that we're treating for very large lung tumors. And I'm just a little nervous to treat them at a higher pressure. I don't know if it's a real fear or not, but I'm afraid I could blow out the lungs at higher pressure. So we've started treating those at lower pressure as well. And most of the patients currently are receiving 60-minute treatments once you reach the desired pressure. So you have to slowly get them up to pressure because you can't just jump up to the high pressure all at once. And that usually takes about 15 to 20 minutes to get up to pressure. And once they're at optimal pressure, we treat them for 60 minutes, and then it takes another 15, 20 minutes to get them back down to normal pressure. So this is what the inside of our chamber looks like. This is a metal tray, actually slides out. Most of the patients we just lift into the chamber. We have a few that we have to put in butt backwards because they are butt in first because they're just too nervous going in forward with that closed chamber. We actually bought a ramp as well. I can't see this. There's a ramp in the background that you can see. We have a few patients that they won't come out of the chamber, and so this ramp has helped them to get out of the chamber, especially we have a large Great Dane that you'll see here. This is Murphy Brown, who has a distal radial osteosarcoma. She's one that we have to put in and back in first because she just refuses to go into the chamber. She, unfortunately, is a little snappish at times, so we have to muzzle her. And then, of course, we take all of her jewelry off before we close the chamber. The smaller dogs can be treated in these plexiglass kennels. We confine them a little bit more in their space. And you can actually fit 2 of these plexiglass kennels into this chamber. So there's some possibility you can treat 2 patients. This particular dog barks at everybody, so we don't treat him with anybody else. So here we have Snoop Dogg, our little corgis, being slid into the chamber, and then we close the chamber. And they have the portholes here, so the dogs can actually see us and hear us, and there's also a camera here, so we can visualize them, especially if they get turned into a corner. I have a technician that sits here or by the chamber, and for the entire time, they're always in visual contact with that patient. You can see him through the portholes here. This is Bishop Anthony receiving his treatment. So how can hyperbaric oxygen therapy benefit the veterinary cancer patient or cancer patient in general? It can be used for treatment of non-healing wounds post-surgery, treatment of radiation injury, treatment of chemotherapy extravasation, pain relief. We found some of our patients have experienced pain relief with arthritis that are undergoing HBOT sessions for their cancer. But it could enhance our anti-cancer therapies as well, and that's something that we're interested in exploring. HBOT has been demonstrated to be helpful for wound healing. It's very well documented that it promotes blood vessel formation, controls infection, and it's been shown to improve healing time in reconstructive surgery of human patients after radiation therapy. Late radiation injury is a relatively common complication in human oncology. Destruction of nutrient blood vessels in local irradiated area can result in local poor, non-healing ulcerated wounds, osteonecrosis, and bleeding. Late radiation changes are characterized by fibrosis and end arteritis, and if the nutrient blood vessels are significantly narrowed, and if there's inadequate oxygen is available to meet metabolic demands, frank aseptic necrosis occurs. It does take some time for this to happen. It can happen months to years later. Radiation therapy for abdominal or pelvic tumors may result in radiation-induced cystitis, enteritis, and proctitis. Radiation therapy for head and neck cancers may cause osteonecrosis of the jaw, dental cavities, dry mouth, and hoarseness. Oops, I keep forgetting this doesn't work. Radiation to the chest wall for breast or lung cancer may result in soft tissue radionecrosis of the chest wall with reduced range of motion or swelling of lymph nodes. And HBOT has been shown to induce neovascularization and reduce the fibrosis in radiated hypoxic tissues. HBOT in human medicine has shown dramatic success in treatment of osteonecrosis of the jaw in humans and is now the treatment of choice for treating osteoradionecrosis. In patients with radiation cystitis, 82% of them will improve with HBOT treatments. 60 to 70% of human patients with radiation enteritis and proctitis will improve with HBOT. And in reconstructive surgery involving irradiated tissue, HBOT prior to surgery can help promote a well-vascularized wound, enhance healing in the reconstructive process. How about HBOT for chemotherapy extravasation? We all know that there are certain drugs that we use on a daily basis that can be vesicants. If you know that the extravasation has occurred, the immediate treatment is to aspirate any chemotherapy from the catheter, elevate the affected extremity. You either cool them, use cold packs or warm packs, depending on what drug was extravasated, local anti-inflammatories and analgesics for pain. And of course, you can use any of the antidotes specific for the chemotherapy drug that was extravasated. But what happens if your patient comes in with a leg that looks like this? In many cases, these patients have to have extensive surgical debridement or even amputation in some cases. There's been a lot of chatter on the listserv lately about treatment for chemotherapy extravasations, and this is one that happened to me. We did not know, the technicians that gave the chemotherapy drug did not indicate a problem. We did not know the extravasation occurred at the time, so of course we didn't do anything. This dog presented, he was being treated for lymphoma, was on a Q3-week doxorubicin treatment, came in about 2 weeks after his third dose of doxorubicin because of his leg, and this was very swollen, very painful to the dog. It was hot, and of course all the tissue necrosis. So this is Jack's, and this is a close-up of his leg. So we decided at this point, damage was done, let's stick him in hyperbaric and see if we can heal him up. So we actually did 10 treatments, so we did 5 treatments a week for 2 weeks. And this was his leg, probably about midpoint of treatment, so all the necrotic tissue is gone. We have a very good granulation bed going. This was about the end of the hyperbaric treatments, and his leg healed up without incident after that. We never did any surgical debridement. We never obviously kept his leg, but we never did any surgical debridement. The only treatment he had other than pain management, because he was very sore on that leg, was the hyperbaric therapy. And we did continue on with his doxorubicin treatments. He unfortunately died of his lymphoma about 3 months later. And just as an aside, insurance companies are paying for hyperbaric oxygen therapy. This dog had all 10 treatments, and we charge roughly about $200 a treatment. They paid for all of the treatments. And we had a little dog with inflammatory brain disease that the insurance company paid for 40 treatments of hyperbaric for her. But can we use hyperbaric specifically as a cancer treatment? We certainly know we can use it for side effects of the treatments we're giving. It's been well established that solid tumors contain areas of acute and chronic hypoxia. The severity of hypoxia can vary both within and among different tumor types, and the tumor cell's ability to adapt to the hypoxic microenvironment can allow tumor cells to survive and proliferate in this hostile environment. And hypoxia can then lead to a more aggressive tumor phenotype and can promote tumor progression and resistance to therapy. Hypoxia has been suggested as a negative prognostic factor for patient outcome in some human cancers, independent of standard factors such as tumor stage and nodal status. Studies have also suggested worse disease-free survival for patients with hypoxic cervical cancers and soft tissue sarcoma. And in head and neck cancer, studies suggest hypoxia as a prognostic factor for survival and local tumor control. So can HBOT overcome tumor hypoxia? Studies have found that similar to normal tissue, the pressure of oxygen in the tumor tissue significantly increases during HBOT. And the elevation of tumor oxygen pressure has been shown to be preserved clinically for 30 minutes following HBOT. There has been some concern that the increased oxygen could stimulate tumor growth, but this has been countered by years of data in HBOT for radiation injury, including osteoradionecrosis. Patients receiving HBOT as part of the reconstructive process had significantly less cancer recurrence than those patients that did not receive HBOT. And reports from Japan in the late 90s show that HBOT given prior to radiation therapy resulted in a 50% increase in survival. Pretty interesting. What I'm interested in, I'm not a radiation oncologist, so we certainly have one in town we could consider working with, but I'm a medical oncologist. I want to know, can I give chemotherapy with HBOT? Can I combine those treatments together? And could I potentially improve responses in tumors that are not responding to chemotherapy or that historically chemo-resistant? So as we stated before, the oxygen pressure in the tumor tissues increases significantly during HBOT, and that's been shown to be preserved for 30 minutes. Hyperbaric may overcome chemotherapy resistance by increasing the tumor perfusion and cellular sensitivity to chemotherapy drugs. There's a number of models out there in the human literature. One such model, a mammary tumor model, the uptake of chemotherapy in cells was increased for the duration and immediately following hyperbaric. HBOT increased the tumoricidal action of doxorubicin in rat sarcoma cells in vitro. So a lower dose of doxorubicin when combined with hyperbaric obtained the same effect as a higher dose of doxorubicin alone. And then they used this particular in a rat model where they treated rats with metastatic lung cancer from the same sarcoma line. And when the rats treated with doxorubicin and HBOT, they found significantly reduced the number of lung metastases and lung weight compared to either doxorubicin alone or HBOT alone. Another study suggests there might be, the timing of HBOT might be important. When given gemcitabine in a pancreatoductal ductal tumor cells in vitro, when the HBOT was administered before or after gemcitabine and had no effect on apoptosis. But when it was given during gemcitabine administration, it significantly enhanced gemcitabine-induced apoptosis. Again, suggests the timing that HBOT and chemotherapy administration is important and could be drug-dependent. There's a lot of evidence in human medicine that HBOT may potentiate the side effects of chemotherapy, but these are all in vitro studies and rodent models. As we like to say, if you're a rat, we can take good care of you, but what happens if you're a dog or a cat or a human? So questions we have are, can chemotherapy be safely administered concurrently with HBOT? Will doses of the chemotherapy drugs need to be reduced, and by how much? What's the dose-limiting toxicity of these drugs when given with HBOT? And is the combination of HBOT and chemotherapy effective or more effective? And could it be effective at a lower dose of the drug? And the bottom line is, I don't know, because there's nothing in the literature that tells us how to do these. So we started a little pilot study basically to try and answer some of these questions. There's absolutely nothing in the literature to suggest how we treat these guys, what doses of the drug to use. So we started a study. We were just admitted any patient, dog or cat, with any type of cancer. We currently have treated 21 patients. We have 3 cats and 18 dogs with a variety of tumors. We're looking at a number of different drugs. Some of them are the ones that we use most commonly in practice. So mitoxantrone, doxorubicin, carboplatin, and CCNU are the drugs we've looked at thus far. We're certainly interested in looking at other drugs. We currently have had 6 patients that we're treating with mitoxantrone, a metastatic anal sac carcinoma, an oral squamous cell carcinoma with 1 in a dog and 1 in a cat, a bladder transitional cell carcinoma, nasal carcinoma in a cat, and a prostatic carcinoma. 4 patients treated with doxorubicin. 1 is a metastatic splenic hemangiosarcoma. We have a metastatic sub-Q hemangiosarcoma. This is a dog with a very large subcutaneous hemangiosarcoma that failed the ImmuneFX cancer vaccine. And we were contemplating sending him for radiation therapy, palliative radiation therapy, but on staging he had metastatic disease to his spleen, so we elected to enter him into this study. This dog's actually had a partial response to therapy, and as a side note, hyperbaric oxygen therapy is really good for getting maggots out of a wound. This dog, we didn't know he had maggots. This dog, because his tumor necrosed and he had an open wound that we were managing, and so he came in for his routine hyperbaric treatment, and the nurse is calling me after she brings him out of the chamber, like there's maggots crawling all over our hyperbaric chamber. So they don't like the hyperoxygenated tissue, and they'll come out of the wound for you. We have one dog, actually. Most of these dogs that were treated in this study are gross disease, but we do have one dog with a high-grade soft tissue sarcoma that's incompletely excised that's getting doxorubicin with HBOT as an adjuvant. And we just entered a dog that's a year out from amputation and carboplatin chemotherapy that has a lung metastases from osteosarcoma. We have 4 patients treated with CCNU. One is a suspected spinal plasma cell tumor and a suspected spinal lymphoma. These dogs had advanced imaging that showed masses, but we did not have a tissue diagnosis of type. We have a cat with a GI lymphoma and a solitary osseous plasma cell tumor. 7 patients we're treating with carboplatin, one of whom had previously received the combination of doxorubicin and HBOT. We have one dog that's a histocytic sarcoma. Initially, when we entered the dog in the study with carboplatin, we thought it was an osteosarcoma, but when the cytology came back, as we sent the cytology off, it was a Bernese mountain dog that had big lytic bone lesion and came back as a histocytic sarcoma. Unfortunately, those owners put that dog to sleep before further treatment. We would have liked to switch the dog to CCNU and continued the trial. A nasal chondrosarcoma. This is the dog that had previous doxorubicin. This dog is a dog that had over 100 treatments of hyperbaric oxygen therapy. He was one of the first dogs that we started with when we received our chamber, and he continued for twice a week for a year until his death recently from brain involvement. We have one dog with a metastatic carcinosarcoma, a nasal carcinoma, and a metastatic vaginal carcinoma. So how we do the study is we give the hyperbaric first. We're going under the presumption that we'll treat hyperbaric first, get those oxygen pressures up, and those oxygen pressures in the tumor tissue will be elevated for 30 minutes. Most of the dogs, unless they're brain spinal or a large lung tumor, if we have a nasal tumor that does not have advanced imaging, so I don't know if there's brain involvement, we treat them at 1.5 ATA. All the other dogs are being treated at 2 ATA for 60 minutes. The chemotherapy is administered within a relatively short time of the pet exiting the chamber. Our hyperbaric chamber is on the other side of the hospital, so what happens is the technician that's doing the treatment calls the treatment room, says, I'm decompressing, or if they send me a text with autocorrect, they're often decomposing the patient. But they decompress the patient. They let us know that they're decompressing the patient, and we get all the chemotherapy ready to go. And so the patient is walked over from hyperbaric to the treatment area and is immediately given the chemotherapy. Because I had no idea how high a dose I could go or how low a dose I should reduce them to, we elected to start them at 50% dose reduction. So the carboplatin dogs, for example, are getting 150 milligrams per meter squared, the very first treatment. And then each subsequent dose is increased by 30 to 40% until either we get a dose-limiting toxicity for that patient or we reach the full standard dosing of the drug. Most of the dogs we're seeing myelosuppression with the combination therapy, and we're seeing it at a lower dose. So we do think there's some additive effect with the combination therapy. So for the dogs that are receiving mitoxantrone, it appears that the highest dose we can give them is somewhere between 4 to 4.5 milligrams per meter squared. There's always those outliers. Our little corgi that you saw earlier with the bladder transitional cell carcinoma just received 5 milligrams per meter squared at his last treatment earlier this week. We've seen a few dogs with mild GI toxicity, a bit of nausea and diarrhea, very, very mild, usually treated at home with medication. And most of these dogs are getting myelosuppressed. And so my decision on whether to escalate them or not is they didn't have considerable GI effects, side effects, and their neutrophil count stayed above 2,000. If that's the case, I will up their dose of chemotherapy. If they're starting to drop on their neutrophil count, we'll say, well, this is the chemotherapy dose we're going to continue for subsequent treatments. The doxorubicin, we found that most of the dogs can't tolerate more than 25 milligrams per meter squared because they get pretty myelosuppressed. I have not noted any GI toxicity in the dogs with the hyperbaric in this dose of doxorubicin, but we are seeing significant myelosuppression. Many are having neutrophils less than 1,000 at this dose. And one dog with metastatic splenic hemangiosarcoma was hospitalized for 3 days with fever and neutropenia. It did resolve. Unfortunately, we lost him to his disease shortly thereafter. Our dog with the high-grade soft tissue sarcoma that's being treated as an adjuvant was escalated last time to 27.5 milligrams per meter squared, had no neutropenia on his 1-week CBC, and so he's going to receive 30 milligrams per meter squared of doxo in combination with HBOT at his next treatment. With CCNU, most patients are able to receive somewhere between 50 to 60 milligrams per meter squared, depending on the size of the patient. The 2 spinal cord tumor patients were euthanized very shortly into the protocol. One dog only received 1 dose, and so we had initially given her dose at 40 milligrams per meter squared, but there was no problem. The other spinal cord tumor dog went through 2 doses, and she did tolerate up to 60 milligrams per meter squared. One small dog, and this is our dog with the solitary osseous plasma cell tumor, is receiving 50 milligrams per meter squared for a total dose of 20 milligrams, which is about what the small dogs receive without the hyperbaric. And we have a very large cat that's getting 55 milligrams per meter squared, and he's getting 20 milligrams of CCNU with this hyperbaric with no problem. Have not seen any GI side effects with the CCNU combined with hyperbaric, and myelosuppression seems to be our dose-limiting side effect. And most of these patients, this myelosuppression we note on the CBC. None of them have been sick. None of them have. Some of them have required prophylactic antibiotics because they were low enough to be concerned, but other than that one dog was the only one that was severe enough to be hospitalized. Everybody else has been relatively mild. Carboplatin, majority of the patients will tolerate 250 milligrams per meter square, but many of them I can't get higher than that. I have a few patients that were able to tolerate the 300 milligrams per meter squared. We've seen mainly inappetence for GI side effects with the carboplatin and myelosuppressive, and some of them have been persistently neutropenic at 3 weeks, and we've had to go to a 4-week interval. And the hyperbaric's given just at the time of the chemotherapy. So whatever the chemotherapy schedule is for that particular tumor type, the hyperbaric's just given prior to that. So if they're on a Q3 week doxorubicin schedule, hyperbaric's Q3 weeks as well. Response to therapy. It's a little early to really make comments about response to therapy. Most of our patients that we've entered in the study are just now reaching those maximum doses, although we're not seeing responses at the lower doses at all. We always have to keep in mind, like any good clinical trial, most of the patients that have been entered into this little pilot study have advanced disease and have failed multiple previous therapies, so it's possible that we're not going to see a response at all, but if we do, it'll be exciting. I'm hopeful that as we escalate these drugs up, that we will get responses. We're going to continue to enroll patients. I've had a few that have reached the full standard dosing of a certain drug without any response. And so we're going to change the chemotherapy drug and see if we get a response with a different drug. New patients to be enrolled in the study, we're going to start at a higher dose, and we'll dose escalate if no side effects. I have a pretty good feel, as I've indicated, what they'll tolerate. So we just entered the metastatic osteosarcoma earlier this week with doxorubicin, and we started him at 25 milligrams per meter squared because that seems to be the highest tolerated dose. But if he doesn't have a problem, we'll see if we can escalate him up to 30 milligrams per meter squared. We'd love to look at some other drugs as well, including vincristine and vinblastine. And the timing of chemotherapy to HBOT, I mean, we're guessing based on those few studies that are out there that the oxygen pressure is higher, and that's the best time in that first 30-minute window to give the chemotherapy. But that gemcitabine said, maybe you need to give it at a different time. The challenge with our chamber is we can't give chemo during HBOT. They're locked in there, and you've got to decompress them to get them out. So for now, we're going to stick with the post-HBOT treatment. Sometime in the future, we may consider giving the chemotherapy first and then doing the hyperbaric. And one of the things we're interested in doing, and I've certainly contacted Paul Jaffe at HVM, so I'm like, how can we measure the tumor oxygen pressure in the tumors? Is there a way to do that? And there's some older studies that use something called an Eppendorf oxygen probe to do that, but I can't find that anywhere, so I'm not sure they're being made. They're probably expensive, even if I can find it. But there is a company I found in Britain called Oxylite that I've sent an email to see whether their oxygen probes might be helpful to answer that question. It'd be really interesting to measure the oxygen pressure in the tumor before hyperbaric and after hyperbaric to see if that holds true in the dogs. Just wanted to show you one of our patients that we've treated. This is Dakota. He's a 6-year-old Labrador retriever. We saw him. He's out about 2.5 years from a non-resectable maxillary squamous cell carcinoma. We originally put him on Palladium, had a complete regression of his tumor that lasted for 18 months. Tumor recurred, and we started him back on Palladium. We treated him with Palladium for 6 months. He had been off of Palladium for a year. Put him back on Palladium, no response to therapy, so we entered him into our trial. He's received 3 doses of mitoxantrone. His most recent dose, we were able to escalate him up to 4.5 milligrams per meter squared with no side effects, no neutropenia noted. And he's got considerable disease. He's got a very large mass here on the right side in the bridge of his nose. He's got swelling hair, and of course there's this tumor eating away at his lip. But we do seem to have some regression. He's still got the big bump here, but it measures the same as best I can tell with my calipers. The swelling hair has gone down significantly, and this tumor has regressed partially as well. Interestingly, the owner has noted to us that the tumor goes down significantly right after hyperbaric, and then by the time his 3-week interval comes back up, it's starting to grow again. Of course, we see that with chemotherapy alone as well. So we're thinking about maybe escalating him to every 2 weeks if we can, if he'll tolerate that, and see if we can get a better response. But he feels good in spite of his ugly tumor. And I'll stop there and turn it over to Dr. Turkell.
Good afternoon. I know the hour is late. My request from ACVIM was talking about hyperbaric oxygen in internal medicine. So this is going to be a much broader view, but I think you're going to find it extremely interesting. First of all, how many people in the room practice with a chamber? 1, 2, 3. That's great. Also, I want to bring to your attention on my bio, the last number of letters behind my name, CHT-V, is a new approved veterinary certification for hyperbarics. It is hyperbaric technician, veterinary, certified. This is something that you all can be certified in. It's something you should pay attention to, and provided by the National Board of Diving and Hyperbaric Medicine. What I want to talk about is a large question that I have in my mind, and that's the difference between human hyperbarics and the amount of treatments we find in this country and around the world in veterinary hyperbarics. What you're seeing here is multi-place chambers. These chambers allow multiple people going inside a chamber. The chamber is filled with air. And as you see in the top photo, there's little space-age hoods over the patients inside the chamber, which is filled with oxygen. It's much cheaper and much safer than filling a gigantic vessel with oxygen. These are what monoplace chambers look like on the human side. There are thousands of these chambers around the United States. One person goes into each chamber one at a time. Here is a gigantic human chamber, 40 inches diameter, being installed in the Jupiter Medical Center. This is the largest monoplace chamber that we have manufactured in the world. This chamber has been used predominantly for research and development in the bariatric surgical sector of the Jupiter Medical Center. They made them so large because some of the patients are so huge, they can't fit into a regular chamber. But the question at hand is, why are there so few veterinary chambers? This chamber was manufactured in the early 70s. Imagine squeezing yourself into that. This chamber is in Broome, Western Australia. There's also one of these you can actually see in Isla Mirada, Florida. And this was predominantly for decompression disease, divers who came up too quickly. But that's thousands of chambers treating thousands of people every day. but less than 50 chambers in the veterinary community across the country. And the question is why? This is a C-class chamber. It is for animals only. It's the chamber that's manufactured by Hyperbaric Veterinary Medicine. But the question still remains, why? One reason is when I went to vet school, they didn't teach us about hyperbarics. There's only 2 vet schools in the country right now that teach hyperbarics and that have hyperbaric chambers. It's Tennessee and Florida. Probably part of the reason may be that during the 70s there were many new innovative and effective therapies that became available. Possibly also efforts to overuse it for various medical conditions proved unsuccessful in the early 70s. And then there were rogue physicians who were high-profile HBOT advocates that probably damaged its reputation early on. But the science prevails. Veterinarians understand that most medical problems are not uniquely human, nor are most of the treatments. And that's kind of what I'm trying to bring together here. Dr. Barbara Naderson Horowitz, a cardiologist at UCLA Medical Center, coined the term zoobiquity to describe the idea of human physicians looking to animals and the doctors who care for them, veterinarians, to better understand human health. Veterinary medicine had not been on her radar until about 10 years ago. That's when she was asked to join the Los Angeles Zoo as a medical advisor. And she began hearing about congestive heart failure in gorillas, leukemia in rhinoceros, breast cancer in tigers, pandas that got eating disorders, or flamingos that got heart attacks, and koala bears that got STDs. Veterinarians understand the similarities between animal and human disease, and also understand the similarities in the treatment of these diseases. We often use human drugs that haven't been tested or approved, but we use them anyway. So the point here is not needed to reinvent the wheel. We should look at the science of hyperbarics on the human side for our direction. So let's look at the reverse for a moment in regards to HBOT. What conditions did the FDA approve for humans that we can assimilate into the veterinary medicine market? Before we do, just realize that the FDA and the Undersea and Hyperbaric Medical Society is an organization representing physicians and nurses and technicians in the field of hyperbaric medicine. Oxygen cannot be patented. Profits on the sales of oxygen are too small to pay for studies that meet the FDA requirements. Human and medical insurance companies commonly take the position that the FDA has not issued formal approval. So the 14 below indications have been detailed in physiology, medicine, and clinical evidence. This means that these are what the FDA believes is indicated and insurance companies will pay for the treatment of hyperbarics in humans. So, air or gas embolism, carbon monoxide poisoning, clostridial myositis and myonecrosis, crush injuries, compartment syndrome and other acute traumatic ischemias, decompression sickness, enhancement of healing problem wounds, diabetically derived illnesses, exceptional blood loss, intracranial abscess, necrotizing soft tissue infections, osteomyelitis, delayed radiation injury, skin grafts and flaps, and thermal burns. So what does this look like in veterinary medicine? So what you see here is a chest x-ray of a 5 to 6 month old male domestic short-hair kitten presented for neuter or declaw, died on the table. Cat was normal on physical therapy prior to surgery. There is air in the cranial vena cava, there's air in the right side of the heart, and there's air in the liver. Where did these come from? Most likely an IV line. But other ways that air can get inside your patients: injection, lung trauma, diving, explosions. Hyperbaric oxygen therapy is used to reduce the size of these bubbles circulating blood vessels. HBOT for carbon monoxide poisoning. There is more cyanide in smoke than carbon monoxide. It's very sobering to realize how many people and pets are affected by carbon monoxide every year. We provide veterinary oxygen masks to the fire departments in our community and remind them to bring any pets found at our fire site with suspected smoke inhalation to our hospital for HBOT. HBOT for gas gangrene. The black necrotic tissue with evidence of gas-producing bacteria in the mammary gland warrants immediate surgical intervention. There is gas gangrene in these glands. We see this. HBOT, in conjunction with surgical debridement, will provide a better outcome. And used prior to surgery may indicate more clearly the line of demarcation between viable and unviable tissue. HBOT for crushing injuries. The crushing injuries on the veterinary side caused by hit by car and by bite wounds. We see these every day. This dog bit into a chainsaw that was on. I thought this was really interesting because I was going to say, how could we talk about HBOT and decompression disease, but look how many people are teaching their pets how to dive. I was astounded. This is just a matter of time before there's going to be an accident. HBOT for arterial insufficiencies. On the human side, this is huge, especially for diabetic foot ulcers, and has prevented numerous amputations. Here are some of the veterinary cases that would benefit. Problem wounds. More problem wounds. HBOT for severe anemia and acute blood loss. Hyperbaric oxygen treatment is equivalent in wholesale cost to a unit of packed red blood cells in the Western world. By controversy, but true, hyperbaric oxygen provides a low-technology, cost-competitive means of pharmacologically reducing accumulated oxygen debt in the anemic, injured, or critically ill patient with little side effect. If hemoglobin falls rapidly and symptoms of cerebral anoxia appear, intermittent hyperbaric oxygen therapy will have a striking effect on the cerebral symptoms and keep a patient alive during the critical period. In 1960, an experiment by a Dutch doctor put a pig in a hyperbaric chamber, pressurized it to 3 atmospheres, which is equivalent to being at 66 feet under seawater, replaced its blood with saline. The amount of oxygen dissolved in the saline kept the pig alive in the chamber without blood. At the end of the experiment, the doctors took the pig out, replaced his blood, and the pig survived. HBOT and intracranial abscesses. The accumulation of infected material, these abscesses in the brain are common in patients with head trauma. Another FDA-approved use for hyperbarics. Hyperbarics for necrotizing soft tissue infections. Could be from flesh-eating bacteria that usually progresses very rapidly. We've all seen cases that are similar to this in our practices. Indications for hyperbarics that are approved. Hyperbarics for osteomyelitis. Hyperbaric oxygen appears useful for the treatment of osteomyelitis for a lot of reasons. One of the big ones is Pseudomonas does not like to live inside hyperbarics. It also increases the oxygen tension in infected tissue. Adequate oxygen tension is necessary for oxygen-dependent killing of organisms by leukocytes and for fibroblast activity lending to angiogenesis. Betsy talked about radiation. Hyperbarics for post-radiation injury, radionecrosis, radioosteonecrosis. Soft tissue radiation necrosis and radioosteonecrosis are common sequelae for the radiation patient, and they benefit extremely well from hyperbarics. New evidence has been shown that if you hyperoxygenate a patient in a chamber just prior to radiation, you enhance the radio effect and you have much, much less collateral damage. If you perform radiation, you should have a chamber in your practice. Hyperbarics for compromised skin grafts and flaps. Those of you that see grafts and flaps medically after surgeons have completed their advanced arts and crafts, put them into a chamber to enhance the angiogenesis and oxygenation of the wound edges. These tissues are severely traumatized, and they need all the help they can get. HBUT also decreases edema along with tissue margins. Hyperbarics for thermal burns. I don't have to talk to you about burns. You've seen burns. This is a case that was in my hospital. A third of the body was burned. The dog was found in the streets of Miami covered in maggots. All we did is debridement in this dog and hyperbarics with a little bit of Silvadene. Day 2, day 7, day 20, day 30. This one I really couldn't find a comparisons, but I did find an interesting photo. Hyperbarics for idiopathic sudden sensory neural hearing loss. They're using it in people. I'm not sure how we can yet integrate it into veterinary medicine, but someone will figure that out. So those were all indications that the FDA and insurance companies are paying, and thousands upon thousands of people are being treated daily across our country. And there's less than 50 chambers in the veterinary community. The following indications have been introduced due to a growing body of evidence in support of using hyperbarics. Stroke, multiple sclerosis, head injuries and contusions, infections, Lyme's, heart attacks, chronic fatigue, ADD, ADHD, sports industry. The list goes on and on. Crohn's disease, fibromyalgia. Aetna Insurance, one of the largest in the United States, considers the use of hyperbarics experimental and investigation for these conditions plus about 100 others. There's still some insufficient evidence, according to the FDA standards, in the medical literature establishing that systemic hyperbaric is more effective than conventional therapies. But the evidence on a daily basis is growing. Veterinarians have the ability to pioneer this work. If a window of opportunity appears, don't pull down the shade. For some of these indications, accumulating evidence may continue to support the effectiveness of hyperbarics. Advantages of adaptive licensing. The basic concept is the heart of the adaptive licensing approach is that the review process should be a learning system. It shouldn't take $1 billion to prove the minutiae within FDA. Breakthrough therapies would be made much available to patients much earlier in the regulatory process. So don't let the mandated evidence slow down the research. The reviews should be clear, present, and the recommendations consistent with the evidence. Veterinarians have the ability to pioneer these indications. So these indications I'm talking about right now are the ones that FDA has still not approved, but the evidence is becoming overwhelming. Stroke. Stroke is an ischemic event. In a review of 222 patients, the American Stroke Association suggests that a significant number of these patients with completed stroke will benefit from hyperbarics. The otherwise normal cells in an ischemic event go dormant because they cannot function without appropriate oxygen. When the cells in the brain or elsewhere die, either from trauma or lack of oxygen, blood plasma leaks out into the surrounding brain, causing tissue swelling and reduced blood flow. HBOT dramatically increases the oxygen carried in the blood plasma. These are post-metabolic areas of uptakes, the ones that show pre and post. The uptake is orange. So why not use hyperbarics in heat stroke, spinal cord stroke, FCE, vestibular disease, cerebral vascular accidents, transient ischemic attacks. Personally, after I have observed my patients in hyperbarics, and I've been treating patients for over 4 years, if anyone ever near and dear to me had a stroke, they would be treated conventionally, but they would also get into a chamber as quickly as possible, because in my belief, it will increase the maximum medical recovery. Hyperbaric oxygen treatment in post-operative neurosurgical infections. Not just infections, but just post-neurosurgical surgeries. But HBOT for neurological applications is a common practice around the world. Probably more common in Russia, China, and Japan. Published research on HBOT in a wide variety of acute and chronic neurological diseases. The general finding has been successful therapy with high-pressure HBOT in the first few hours after a cerebral insult, and then tapered to low pressures in the weeks and months to follow. 39 consecutive patients, Larson Engström in Sweden. Objective to evaluate the clinical usefulness of hyperbaric oxygen. Conclusions: HBOT is a safe, powerful treatment for post-operative cranial and spinal wound infections and should be included in the neurosurgical armamentarium. I found this to be really interesting. A review of systemic inflammatory bowel disease. 13 studies of HBOT in Crohn's disease. And this is touching everybody because you all know people who have these diseases. How do we manifest it into veterinary side? Crohn's disease is considered to be an autoimmune in origin. There's increasing evidence it may have an infectious cause in addition. HBOT lowered the markers of inflammation and oxidative stress and ameliorated IBD in both humans and animal studies. Most treated patients were refractory to standard medical treatment. This is interesting. We all know leg calf perthase disease. In this study out of Israel, for avascular necrosis of the femoral head, 81% of the patients who received HBOT showed a return to normal on MRI compared to 17 in the untreated group. Potential effects of hyperoxygen therapy in acute pancreatitis. Acute pancreatitis impairs the pancreatic microcirculation, causes acute inflammation. 20 to 30% of the patients develop pancreatic necrosis. These processes are ischemic in nature and potentially improved by driving oxygen into the ischemic tissues and currently reducing pancreatic inflammation-associated pain. When I have a pancreatic, I'm also a practitioner. I know that they didn't use that as my introduction. I have a practice in Boca Raton, Florida, and I've been using hyperbarics there for 4 years. If I take a pancreatic patient and I put it in my chamber, and that dog is standing there, splinted abdomen, really uncomfortable, during the 45 minutes he's at pressure, you wind up seeing them become comfortable. They lie down, they curl up. They are relieved of the tension and pain inside their belly. This is an interesting study, Cardiology Review 2009, and I'm going to put a little footnote in here. There's a lot of encouraging work with regards to hyperbarics, and it's used in conjunction with thrombolytics to reduce the magnitude of injury in patients with acute myocardial infarction. Keywords here are HBOT in conjunction with thrombolytics and reperfusion injury. This is all about how to decrease reperfusion injury, and HBOT plays a major role in preventing reperfusion injury. This guy got beat up on the football field for many, many years. Football legend Joe Namath helping to bring publicity to treatment of brain injury with hyperbaric oxygen. Researchers discovered that hyperbaric oxygen was helpful for a host of other conditions, including brain trauma, stroke, multiple sclerosis, cerebral palsy. I've seen some amazing effects with that. Autism in children and Alzheimer's. Namath underwent 40 sessions of hyperbaric oxygen therapy over a period of 6 months. And his doctor says that they haven't seen an improvement in traumatic brain injury as substantial that they have seen in this sports hero. Lyme disease. Although additional statistic evaluation is still being carried out, it appears that approximately 84% in a almost 2,000 treatment study in 91 subjects, 84% of these treated showed improvement by a decrease or elimination of symptoms. It's thought that the Lyme bacteria can survive in hyperoxygenated environments over 2.3 ATA. Personally, I normalized IDEX Lyme quantitative C6 results in 30 days with a combination of doxy and hyperbarics. Stem cells. This is a whole different world. Steve Tom et al. in 2005 at University of Pennsylvania, over a course of 20 HBOT treatments, increased CD34 stem cells. The CD34 stem cells are the primitive blood and bone marrow-derived progenitor cells, 8-fold. 20 dives increases your stem cells 8-fold. I did a very, very interesting study. It was based on an experiment in Argentina on type 2 adult onset diabetes in 30 people, most of which went into some duration of remission, somehow turning the insulin switch. Remember, dogs are like type 1 diabetics. Pancreas doesn't produce insulin. Cats are like type 2 diabetics. They just can't get the insulin absorbed. The study was dogs and cats given 5 doses of hyperbarics, 5 days in a row, then given 7 days of a granulocyte colony stimulating factor, and then 5 more days of hyperbarics. It was a 17-day treatment. All the cats in this study went completely into remission, no insulin for 6 months. The dog's insulin level actually decreased. So with regards to stem cell and what it does inside the body, we have pathways of pioneering we don't know the answers to yet. So remember, this is a drug. How does it work? The mechanisms: hyperoxygenation, angiogenesis, fibroblast proliferation with collagen synthesis, and vasoconstriction. Also, leukocyte oxidative killing, reduces leukocyte intravascular adherence, reduces lipid peroxidation. That refers to the oxidative degeneration of lipids resulting in cell damage found in inflammatory bowel disease, kidney damage, Parkinson's, asthma, and others. Toxin inhibition, and it synergizes antibiotics. Additionally, evidence is growing that HBOT alters the levels of pro-inflammatory mediators and blunts the inflammatory cascade. More studies are needed to further elucidate this complex interaction. But one of the things that Betsy said earlier are that many of the veterinary pet insurance companies are paying for hyperbaric oxygen, and they're not really interested in the fact that it is used for an FDA-approved indication or not. So we need to pioneer the science into the direction that makes the most sense with clinical evidence on hand. This is what I wanted to share with you. A lot of you have seen this photograph in the last day. This dog had its muzzle tied with duct tape.
A man who North Charleston police say taped a dog's mouth shut because it wouldn't stop barking, still in jail on $50,000 bond this afternoon. William Dodson, whom you see here, charged with animal cruelty. Court papers state Dodson also chained the dog in his backyard, but she somehow broke free. Meanwhile, the dog, named Caitlin, is being treated at a veterinary specialty care center in Mount Pleasant. That's where we find our police reporter, Harv Jacobs, with a very special guest this afternoon. Harv, who do you have there with you?
Well, Bill, take one guess. It's Caitlin. We have her live and alive, thank goodness. Here she is. Sweet, beautiful dog. You can see the injuries on her muzzle. That's where the muzzle was taped shut, allegedly by William Dodson, and she seems to be doing okay considering what happened to her. With us right now, Dr. Henry Bianucci, who's one of the owners here of Veterinary Specialty Care in Mount Pleasant. Doc, the world wants to know, how's she doing?
I think she's doing great. She has responded very well to the wound treatment that she's had so far. She's had a combination of serial wound debridement, which means we're taking away the dead tissue and seeing what's going to live and what's going to die. I think we're down to good tissue now, and she's going to get a definitive surgery tomorrow to close up the open area on her cheek.
What kind of injuries does she have?
She has a serious laceration on her left side, which is right at where the upper lip joins the lower lip, and she has lost part of her tongue. So part of the tongue is going to be excised tomorrow, but not much. There's, as you might be able to see when she's licking there, a lot of it has come back. She's had hyperbaric oxygen therapy and laser therapy, and I think those modalities have both helped to enhance that tissue recovery. So it's going to minimize how much surgery we have to do.
Let's quickly show this is a hyperbaric chamber. How does this work basically?
This is basically 100% oxygen-rich environment under pressure. This is the same machine that you would get put in if you had a diving accident and developed the bends, which is nitrogen narcosis. It puts the body under pressure and it hyperoxygenates tissues. It has a profound effect on swelling, wound healing, and tissue regeneration. And so it's been a big part of her recovery, again, along with the laser treatment and along with these smaller surgeries, these debridements, making it so really by the time we do the surgery, it's going to be far less than would have been the case otherwise.
And you expect soon she'll be able to go to a foster home, hopefully?
My guess is in a couple of weeks she should be ready to be fostered out. Yeah, she's a very sweet dog. She's got a little bit of anxiety, understandably, about men, because I don't know who did it exactly, but that's the assumption. So yeah, but she's a very sweet dog, and she's bonded already with our technicians.
And you told me very quickly if she hadn't been found when she was found a few more days, we would have had a tragedy.
I don't even think it would have gone a few days. I think she would have either overheated due to an inability to pant. She would have become dehydrated because she wasn't able to take in any water. That's really what would have killed her first, either dehydration or overheating.
Well, thank goodness, Doc, great job by you all. What an outpouring of support from the world for Caitlin. And I could tell you this much, there's going to be a long line of people who want to adopt Caitlin. Live from Mount Pleasant, Harv Jacobs, Live 5 News.
So basically, at the end, it's food for thought, a discussion to nourish your mind and bring new ideas to your practice. Thank you all very much.